Let's have a look at the treatments for breast cancer. And we've got surgery, radiotherapy, top right, other drug treatment, chemotherapy, and then what we call endocrine treatment. I'll come onto that in a minute. And I think I just want to run through what happens when you come along, for example, with a breast lump. And you may have heard of this phrase, it's called the triple assessment. And what we do, we examine you, we take some pictures, and we take a sample out, we do a biopsy under local anaesthetic. And that gets looked at under the microscope, and we'll usually get the answer back. It can come back within a couple of days. To get a full answer with all the things we have to test, and I'll go through that in a minute, it takes about a week to give you a full answer. And often that's the worst bit, is waiting to be told what's happening. But it's this triple assessment. You feel it, you take pictures of it, and you stick a needle in it. And if you do all that, you don't miss anything. Possible, but you don't. Remember, most lumps we see are not breast cancer, and I'll come to that again briefly at the end, but most breast cancers do present as lumps. Most biopsies we do are to prove that everything is fine rather than to diagnose a cancer. And that's important too. We do a lot of biopsies on benign lumps, and we can look at the mammograms and the ultrasound scan and say, yeah, it looks fine, but we have to prove it. And if you do all three, you don't miss anything. So after you've had your initial assessment, you've had your examination, you've had your mammograms and scans, we will know, yes, that it's a cancer, we'll know how big it is, and we'll know the type. Most breast cancers are called ductal cancers. There are lobular cancers, there are mucinous cancers, there are tubular cancers, and so on. But that's just a description. Looking down the microscope, we treat them all. And then you know what's called the grade of your breast cancer. Now, the grade is an indication of how quickly it's come up, and that's all it means. So what the pathologist, so someone like Dr. Wells or Dr. Falzon that I showed you, they will look down the microscope at the cancer. If they see a lot of dividing cells, so it's come up more quickly, they will call it grade 3. If they don't see many dividing cells, they will call it grade 1. And if they see an average number, they call it grade 2. And that's all it means. A lot of people misconstrue grade 3 as, oh, that's very aggressive. That's not what it means. It just means it's come up more quickly. Okay, and that's important. Now, we talked about this triple negative breast cancer, and this involves what we call the receptor status. And on your core biopsies from the biopsy, we can measure what's called the ER, again, spelled the American way, that's the estrogen receptor, and about 2/3 of breast cancers are sensitive to estrogen. We also measure the progesterone receptor, again, that goes along with the estrogen receptor, it's a hormone sensitive thing. And the last one on that list is what's called the HER2, and this is whether your cancer is sensitive to the Herceptin drug, which is a type of chemotherapy and is given with standard chemotherapy. And about 1/3 of breast cancers are sensitive to the Herceptin drug. This Ki-67, we call it the Ki-67 in the middle, is more of a molecular measure of how quickly it's come up, so it complements the grade. So you can get a Ki-67 that varies from 1%, very, very slow growing, up to 80 or 90%, which is very quick growing, but again, that's all it means. But this receptor status, ER, PR, and HER2, is what we call the receptor status of your cancer. And if you're not sensitive to estrogen or progesterone or Herceptin, that is what we call a triple negative cancer. And within that triple negative group, there is a higher incidence of the genetic type of the BRCA1 and 2 abnormalities. We will also know from scans whether you have any lymph nodes involved. I'm delighted to say most ladies when we see them do not have lymph nodes involved when we first see them, but some do, and often we will take biopsies of those. So these are molecular markers, again, estrogen, progesterone, the HER2, those are things that constitute, if you like, your triple status. Ladies who are HER2 positive, say, will need the Herceptin drug and will need other chemotherapy. Ladies who are sensitive to estrogen will need an anti-estrogen drug, and we'll talk about those in a minute. But these are the standard molecular markers that we measure. Now, what's changed over the years I've been doing this is that breast cancer treatment is becoming much more individualized. So it's not one treatment fits all anymore. We try very hard to tailor the treatment to a lady's individual breast cancer. And as you remember, breast cancer is not a single disease. It's lots of diseases that happens to occur in the breast. And there are probably as many different sorts as ladies as I see. So it's how do you personalize the care so that ladies get the right treatment, but don't get the treatments they don't need, which might give them side effects. So, not surprising, I'm a surgeon, so I talk a little bit about surgery, mostly about the reconstruction. If you just have a small lump in the breast, you can have what we call a wide local excision. You can just have the lump removed. If you have a larger lump, you may need to have the whole breast removed, a mastectomy for that. Now, in particular, we see some ladies who've got one lump in one part of the breast and another lump in another part of the breast, and both of them turn out to be cancer. Now, the implication of that is that the whole breast is unstable. So if you have what we call multifocal or multicentric disease with two cancers in different areas, you will almost always be recommended to have a mastectomy. Now, we always take a couple of lymph nodes out at the same time. We call this a sentinel lymph node biopsy. Most of the time, that's going to be clear. And what we can do here, we can look at these during the operation, and Dr. Wells or Dr. Falzon will look at those with what we call a frozen excision examination to make sure the glands are clear. In the small number of ladies who do have cancer in the lymph glands, we tend to remove a lot more glands to make sure we've removed all the cancer-containing glands. So surgery is basically quite straightforward. It's either removing the lump, removing the whole breast, and armpit glands. Let's have a little look at the reconstructive options. And they can vary, and different options will suit different ladies. So you might need, on the left-hand side, a simple implant under the muscle. That might be all you need, that might suit you. The more complicated ones in the middle are what we call the autologous tissue reconstruction. Now, this is the ones commonly that people think about as the tummy tuck operation, where fat is taken from the tummy and moved up to the breast. Now, you can take fat and muscle from many other areas. For example, the inside of the thigh, or actually you can take it from the buttock, but in these situations you'll be taking muscle as well. Now, what we've come to understand through studying the blood vessels, that there are blood vessels, we call them perforators, that supply particular blocks of tissue, be it fat or muscle and fat. And you can isolate these blood vessels and remove the block of tissue that the blood vessel supplies, and you can plug the blood vessels back in, either to blood vessels between the ribs or into the armpit, so that block of tissue will stay alive. And these, you like, you used to call them angiotomes, so angio blood vessel tomes, areas supplied by particular blood vessels. And that's why these particular areas are chosen. And ladies having a tummy tuck reconstruction will have a CT scan to look for these perforators. You can take muscle from round the back, and you can use what's called latissimus dorsi muscle. You can swing that round without disconnecting it, and sometimes you'll put an implant underneath that. But you can take tissue, and it's usually fat and muscle to give you the volume you need to replace the breast from the inside of the thigh on the buttock, but it depends on the blood vessel supply. And there are actually lots of different areas you can take it from, but it's identifying the blood vessel and the block of tissue it supplies. The advantage of the tummy tuck one is you just need fat. When we started doing those, actually, we did take muscle as well, but that's quite a defect in the tummy wall, which make you prone to hernias. But you can just take the fat and the skin now, which is why that one's most commonly used. But if you're particularly slim, you may not have enough fatty tissue. We may need to use muscle and fat from elsewhere. But you can use lots of areas, providing you can identify these perforating blood vessels. Nipple reconstruction on top of that, it can be done at the same time, usually done later. And then the nipple could be tattooed to make things look as normal as possible. But like having a hip replacement, a reconstructed breast is never going to be as good as a real thing. Although I have to say, with the reconstruction surgeons we work with, they're pretty good. Okay. So I hope that gives you an idea about how breast reconstruction works. Now, in terms of the other treatments, and you'll remember I talked about chemotherapy or anti-estrogen tablets, which will travel throughout the whole of the body. And the reason that every lady should have, or man for that matter, should have a treatment that covers the whole body is we often think about breast cancer as what we call a systemic disease, something that may already have spread. Having said that, remember, breast cancer is curable if you detect it early, and the best way of detecting early breast cancer is still with regular mammograms. And we talk about these things called micrometastases. Now, that might be one cell that has escaped from your breast cancer and may be sitting, for example, by your left knee. And it may be there at the time we first meet you. We have no test that can detect that single cell. We know that most ladies we treat do not have trouble again, but some do. And people used to talk about their breast cancer coming back, but in fact what probably happened was that cell was sitting by your left knee or in your liver or your lung, and it was always there, and it sat there for 10, 15, 20 years, completely dormant, again for reasons we don't understand, and then something reactivates it. So it's not that breast cancer comes back, it was always there. So what can we do to treat that cell to try and make sure it doesn't come back? So this is where this systemic therapy comes in, therapy that treats a wider area. And in the breast, if you've just had a lump removed, you will have radiotherapy of the breast. Now we know from lots of international studies that having the lump removed followed by radiotherapy is equally as good as having a mastectomy that usually doesn't need radiotherapy, which is why a lot of ladies will just have the lump removed. In the body, we need to talk about endocrine treatment or chemotherapy. Endocrine treatment is fairly easy. If your tumour is sensitive to estrogen, then you will have an anti-estrogen tablet. And there are two broad groups. There's tamoxifen that we've known about since the 60s, and you use this in young women whose ovaries are still working. After the menopause, although you're still producing estrogen at a much lower level, it's not from the ovaries, and you can use drugs called letrozole, these aromatase inhibitors, and there's some evidence in older ladies these drugs are slightly better than tamoxifen, but tamoxifen is still very good. They all come with potential side effects. A lot of ladies get none, but the side effects, like most drugs, is a list as long as your arm. Most ladies get none of them, I'm pleased to say. There is some discussion about how long she'd been on these treatments. When we started using tamoxifen, we gave it to ladies for 2 years, then it was 3, then it was 5, and now there's fairly good evidence that 10 years is better than 5, particularly if you are in what we call a less good prognostic group, where, for example, you had a bigger cancer or perhaps you had a lymph node involved. So often you will be on these drugs, these tablets, for 10 years rather than 5 now. Having said that, again, it's a balance, because some ladies get really rotten side effects, only a few, and if they can make it to 5 years, that's good, and then we'll have a discussion about whether their quality of life is such that they just want to stop the tablets and perhaps accept an increased relative risk that something might happen in future, which, remember, doesn't tell you it's going to. But everything is to be negotiated, discussed, and so on, and everybody's different. So radiotherapy we've talked about. If you've just had the lump out, have radiotherapy, but you might give it in other cases as well. For example, if you had a mastectomy, but it's quite a big cancer or your nodes were involved, you might have radiotherapy. If the cancer is very big, or if surgery is not possible, but just to control the cancer, you might just radiotherapy in a palliative sense. And then we've got to talk about chemotherapy and who gets it. And nobody wants chemotherapy particularly. It's tough stuff, it is. Some ladies have to sail through it. Some ladies will struggle. And if you've got a large cancer, you'll have chemotherapy. And sometimes that will make cancer much smaller. So, for example, if you had a large cancer to start with, and when we first meet, we say, actually, that's going to need a mastectomy, you can make that smaller. We call it downsizing, by giving chemotherapy first. So you end up just having the small lump out as it gets smaller. If you've got a grade 3 cancer, and we remember the Ki-67 is a mirror of the grade. We talked about ladies who have a HER2 positive biopsy, who will have Herceptin that's given with standard chemotherapy. If your cancer is estrogen receptor negative, so tamoxifen and letrozole are not going to work, you still need a treatment that go around the whole body to pick up that potential cell that we can never detect, so you will need chemotherapy. Some ladies with no positive cancer have it, but not all. Some young ladies, and obviously if it's spread beyond the breast and beyond the lymph glands, you will need treatment that goes around the whole body. Now, one of the things that's changed, we've got these tests now that can tell us whether chemotherapy is going to be helpful. Now, it's not for everybody, and in general there are 3 groups of ladies when you're thinking about chemotherapy. There's a group of ladies who have a very small, very early cancer where we know that you're not going to need chemotherapy, so those go to one side. At the other end, you've got perhaps the young ladies with grade 3 node positive cancer where you already know that chemotherapy is going to work. So these personalising tests are not for those 2 groups. In the middle, there's a group where you think, do they need chemotherapy or not? And what you can do with that third, if you like, is you can test the genes in the cancer. And there's a test called an oncotype, there's another called EndoPredict, there are other tests, and these tests will give you an indication of whether cancer will be helpful. So this is a way we're personalising chemotherapy, because what it does, not only does it mean we're giving chemotherapy to the right ladies, but it means that we're not giving it to ladies who won't benefit from it, who would get all the side effects. And actually, when you think about it, even tamoxifen is a personalising treatment, because only 2/3 of ladies will need it. And I can actually remember, as a student, everybody had tamoxifen, which meant 1/3 of ladies had it who didn't need it and would get potential side effects from it. So these sorts of tests can help us work out who will benefit from chemotherapy most. And what we're finding, we're not giving chemotherapy any less often, we're still giving it to the same number of people, but we're actually giving it to slightly different people. So some ladies in that middle group where we thought, well, they probably don't need chemotherapy, turn out they do. And some ladies where you think, I think they don't need chemotherapy, they don't. but you can do that with confidence. These are very well studied tests now that help us work out who needs chemotherapy, so we can give it to the ladies who will benefit from it most.